everyone. Welcome to ASJ Gems. I'm Phaedra, your moderator, and I'm so pleased today to have Dr. Caroline Glicksman with us. She's a board-certified plastic surgeon in New Jersey in private practice in Seagirt since 1991. She attended the University of Massachusetts in Amherst and in 1980 received a BS in microbiology and a BA in sociology. She went on to attend the State University of New York Downstate Medical Center, receiving her MD in 1985. After completing her general surgery training at Mount Sinai Hospital in New York, she completed her plastic surgery residency at New York Hospital Cornell Medical Center and Memorial Sloan Kettering in 1991. She then went on to complete an additional fellowship in cosmetic surgery at the prestigious Massachusetts General Hospital in Boston. She received her JD from Seton Hall Law School and a master's in pharmaceutical and medical device law in 2020. And she's also the past president of the Aesthetic Foundation and a breast surgery section editor for the Aesthetic Surgery Journal. Welcome, Dr. Glicksman.
Thank you. Thank you for having me. I'm also fortunate I want to mention that Dr. Patricia McGuire from St. Louis is on with me, who's my co-author, co-conspirator, co-inventor. And really, I wanted to have her here as well today so that when it comes to question and answers, that period, she can contribute as well. So I'm going to go ahead and play the talk. It's about 26 minutes long. Hello, everyone. I'm Caroline Glicksman. I'm a plastic surgeon in New Jersey, and I was invited kindly by Phaedra and the Aesthetic Surgery Journal to present this episode of GEMS. I'm going to be speaking based on a lot of the research I've done on what we know about BII, an update on the etiologies of systemic symptoms associated with breast implants, and the suggested management of these patients. I'm going to be presenting this morning, but I do want to thank all of my co-authors and co-researchers who contributed greatly to all of the data. So my disclosures briefly. Okay, so what do we know? We know that BII, and I'll be using the terms interchangeably with systemic symptoms associated with breast implants, that patients report symptoms that they relate to their implants. They have no abnormal labs or physical findings to explain their symptoms. And we know that even though we have many years of experience with this illness, it is a diagnosis of exclusion with no diagnostic criteria. The patients may still come into offices requesting removal of their implant with an en-bloc capsulectomy. So what are the facts? SSBI has been reported with all implants. There is no new implant, there is no implant or region of the world where that implant isn't involved. Saline, silicone, textured, smooth by all manufacturers. Patients describe a lot of symptoms. They have over 100 symptoms that have been reported in no specific configuration. And we do know that social media plays an important role in this syndrome or illness. Patients will report that their symptoms do improve with implant removal. So back in 2018, a group of us got together and looked at the leading international hypotheses on the potential etiologies of BII. And that really led and drove the protocol design and all of the subsequent clinical studies and publications that have come out of our research. So the main question, obviously, is do implants cause systemic symptoms? And what are the potential etiologies? Is it something like ASJ syndrome or autoimmune illness of some type? Is it biofilms or bacteria? Are heavy metals involved in the systemic symptoms that patients report? Allergies? Is it silicone toxicity? Does removing the implant improve the systemic symptoms? And is a capsulectomy required? And how long will the patient have symptom improvement? And finally, what is the role of somatic symptom disorders, anxiety, depression, and what we are known as medically unexplained symptom disorders? So if you look back at what I used to say was 50 years of the review of the literature, it's now a 60-year review of the literature as I get older. But we look back to a paper, the first ones that I can find on this, basically a paper by Pernis in 1962 that looked at the adjuvant effect of silica on antibody production. And as you must do with all of these studies, is you look at what the actual study involved. It was repeated intravascular injection of high doses of liquid silica into rats. It produced antibodies against proteins, and therefore they concluded there was an adjuvant effect of silicone. A later paper in 1984 by Mowat, pretty famous paper used in a lot of the sightings by the BII groups, is the anecdotal case of local and systemic symptoms after saline implants in a patient with previous rheumatoid arthritis. But of course, when you dig deeper into these types of papers, you see that the authors cannot exclude that this was a chance happening. If you look through the rest of the literature that I could find on this table, you can see papers from 1964 to 1999 were primarily case reports, patients with connective tissue disease and had an associated implant, but very little of this data was conclusive. There was very little medical histories on these patients, and they were genuinely case reports and one-offs. ASJ syndrome took off since 2011. This literature, with over 100 papers written on the syndrome, was initiated by Schoenfeld, an Israeli physician, who is also heralded as, the world's leading anti-vaxxer. He basically has developed his ASJ syndrome. Also, another branch of this is silicone incompatibility syndrome, where there's no clearly causative agent has been outlined. There's no temporal relationship that has been outlined, and there's no precise or resulting symptoms. The majority of papers, again, are case reports, opinions, reviews, editorials, and repeating the same literature in some of the journals that he is on board with editorial staff, and just seeing these papers sort of regurgitated. So when we began our research, they were mostly retrospective studies, case reports, poor follow-ups, and leading all of this was a lack of control groups or any sort of temporal relationships to the findings that they were reporting. So what were the goals of our study? And this is, sort of rehashing literature that's been out there now since, 2019. But basically, our goals were to prospectively follow symptomatic patients and 2 control groups for symptom improvement after implant removal. And we wanted to do some very high-level, detailed evaluation of the biospecimens, looking at peripheral blood, capsules, histology, breast tissue, looking for any objective measurable differences that could be used to make a diagnosis or point to a cause of symptoms in these patients. So the first paper that came out, we looked at the impact of capsulectomy type on symptom improvement, with a rise of explant experts and social media platforms leading women towards getting what they called en-bloc capsulectomy. This seemed to be our first priority, was to look at the effect of symptom improvement based on the type of capsulectomy. And what we found in our BII cohort at 1 year was a significant symptom improvement by any capsulectomy type. We followed 94% follow-up at 1 year and showed no statistical difference based on the type of capsulectomy. So part 1, basically, as I said, looked at the type of capsulectomy: intact, total, partial, and they all showed similar symptom improvement with no statistical difference in the reduction of symptoms based on the type of capsulectomy. The second issue that we wanted to take a look at with Roger Wickstrom, who is a toxicologist, wanted to do a detailed analysis of the heavy metals that could potentially be present in breast implant capsules, and see if this could be a cause for the systemic symptoms found in women. And this study, where we sent off specimens to Eurofins for detailed heavy metals analysis, we did find some heavy metals were detected in the capsules of both cohorts, but they were also found in levels, some of them higher, in control breast tissue in women who had never been exposed to any breast implant or any implanted device. But all levels were found to be in what is considered safe levels of exposure. Part 3 was probably the most expensive and detailed portion of this analysis, where we looked at blood, microbes, capsule histology. We sent specimens up to Brown University, where Marshall Caden was, looking at cytokines. We looked at enterotoxins down in looking at these levels with experts in immunology and allergy at Johns Hopkins. And the data, again, found very little difference, if any, that was statistically significant between the cohorts. So there was a lack of consistent, identifiable biomedical markers that differentiated the subjects with self-described BII from the two control groups. The next study we did was, the question was, well, if you remove the patient's implants, how long are they symptom-free? Or for how long does this symptom improvement last? And we followed patients out to a full year and showed that after explantation by any method, the symptom improvement persisted through 1 year of follow-up. In 2022 to 2024, we launched a no capsulectomy study. The reviewers at ASJ who reviewed our paper did make some interesting comments in that they felt that a limitation of the ASERF biospecimen study was that some capsular tissue had to be removed in all subjects. Therefore, no patient had truly undergone a no capsulectomy or implantectomy. And so we decided to do just that, an implantectomy study. Patients were enrolled in one of two cohorts, and we looked at subjects who consented to removal of their implants without capsulectomy in the BII cohort, and in the non-BII cohort, subjects who consented to explantation or replacement without a capsulectomy. And what did we find? We found no statistical difference in symptom improvement based on the type of capsulectomy performed or any capsulectomy performed. And that paper was published in ASJ in 2024, last year. But capsulectomies, are not without their own share of morbidity, both aesthetic and surgically. Capsulectomies can significantly increase the surgical risk. And again, when you look at ASJ and their publications, they have really focused on looking at all aspects of BII, including the rise in capsulectomies that were being performed along with explantation surgery. And what they found as much as 3 times higher risk of specifically hematoma as a complication after capsulectomy. And that is some of the papers that you see to the right here. We also noted longer operative times, they're more expensive, and they leave patients with more significant aesthetic morbidity, leading to more procedures such as tissue rearrangements and fat grafting and mastopexies. So we also wanted to start to look at what else could be responsible for the systemic symptoms reported. And so looking through the literature, we say, well, what about silicone? That hasn't gone away. And what about the potential for gel bleed, especially with older generation devices? Vanderbroek in 2024 published a paper in the British Journal of Cancer Research where he evaluated 7 women with explanted 3rd generation or later breast implants. And these implants were in for a very short range from 3 weeks to 28 months. And what he found was silicone deposits in the capsules of all 7 patients. Therefore, he suggested that silicone bleed is the etiology of SSBI. However, if you look at the limitations of this paper, there's no information on whether these patients had any previous implant prior to the one that was explanted. There's no information on particle size, which makes a difference on whether the implant came from the gel or the shell. There's no data on surgical technique, incision size, were these placed through tiny incisions with shearing of the shell that embedded into the capsule, or were these large incisions, such as in a reconstructive patient? And finally, there's no clear methodology to reach any conclusion based on the 7 patients. However, there's better literature. So this literature comes from Alan Danino up in Montreal. And what they painstakingly did was count the particle density of silicone that was calculated in the capsules surrounding implants that were sold predominantly in North America. And what they were able to identify with electron microscopy was over 1 million particles were identified in the capsule tissue surrounding silicone implants. Well, that's pretty interesting, finding all of that silicone debris within the capsules. However, when they looked at saline implants, which were the leading manufactured implants in the United States from 1992 to 2006 moratorium, on the saline implants, 0 particles were identified in the capsules surrounding saline implants. And interestingly, if you look at the data from our study, we had 64% of our patients in the BII cohorts had smooth saline devices. So as I say at the top of the slide, silicone is surely not the smoking gun. What about oxylipins and biofilm? There's been some recent literature published on these issues. In a paper in ASJ this past year, by Sinha and Bruce Van Natta and the group from Indiana, they suggest that they evaluated BII patients and control groups for bacterial biofilms, and they utilized EM and PCR testing. And what they did detect was some staph epidermidis and Cutibacteria were detected in the capsules surrounding implants. Well, we did a similar studies because we sent our capsules from our BII patients and control group off to Microgen DX for PCR, and we found no statistical difference between the cohorts with the presence of Cutibacterium and Staph epidermidis, which were the 2 leading bacteria. But they did find they were able to detect bacteria surrounding the implants. Well, we did as well without any statistical difference. And they also found some oxylipins that were detected in the BII group versus the control tissue in the blood. But what we did some further research, talking up to Marshall Caden, who is an expert in this area, who's now down in the University of Virginia, and his feeling is that oxylipin elevation can be temporary and nonspecific, just as you would see in a SED rate in a patient, that these are transient findings and are not necessarily a telltale sign of somebody having a diagnosis of BII. Could the systemic symptoms be related to simply the time the implants were in place? We do know with squamous cell carcinoma of the capsule that may be related to the length of time and exposure that patient had to that implant in place. Could BII be the same? There was a paper that was in 2022 that reported systemic symptoms in women with silicone breast implants, and it looked at the length of time that these patients were exposed to their silicone implants. So we went back and looked at our data, the time and place versus symptom improvement. And what we found that there was no statistical significance to the time the implants were in place versus the number of symptoms at baseline or symptom improvement after explantation by any method. So we were not able to find any evidence that the time and place relates to an increasing risk of BII. So now that we have sort of, to the best of our ability, through the best clinical research that we could perform, rule out bacteria, fungi, enterotoxins, heavy metals, platinum, silicone, cytokines, and allergic phenomena, histology, or the type of capsulectomy has an effect, where does the data lead us? Where does the data lead us after we've excluded biomedical markers as a cause of BII? We have to start to look into the research into healthcare seeking behaviors. And there's a lot of research on this worldwide. There's an excellent paper by Steve Bresnick that was in the Aesthetic Surgery Journal just 2 years ago. There's papers by Jill Newby and Bill Adams that started to look at this several years ago in the Aesthetic Surgery Journal. The ISAPS has papers on medical care utilization. And we start to look at somatic symptoms and the prevalence of somatic symptoms and physician-seeking behavior in the general population. We start to narrow that down to the general population, including women. Are women more likely to seek medical care for systemic symptoms? So research has been going on worldwide in the field of healthcare seeking behavior. So we designed our next study looking to see if psychological factors, including health beliefs and emotions, influence the experience of patients with SSBI symptoms? And should SSBI be classified as a somatic symptom disorder? And is that the direction that we should be going when seeing these patients? So this past June, the paper that we're going to be really highlighting today is Systemic Symptoms Associated with Breast Implants, a psychological study of beliefs and emotions. So the study design was looking at 304 subjects enrolled at 8 sites in the United States and the UK. And again, we looked at 3 cohorts, 116 SSBI patients, 104 no SSBI, and 84 mastopexy patients. And we performed 9 different validated psychological assessments on these patients. We also had these patients complete the study when they first entered a investigator's office before the physician spoke to them to control for any inherent biases in our discussions or our questions or our consultation. So patients were completed this survey upon entering the plastic surgeon's office. And what we wanted to look at were neuropsychiatric factors, physical symptoms without identifiable medical conditions, patients who have excessive thoughts, feelings, and behaviors directed towards these symptoms. And we do know that the more symptoms reported by a patient, the less likely a medical cause will be found. We also wanted to understand the rapid symptom improvement these patients have after explantation and the high incidence that a lot of these patients have with health, anxiety, and depression. The testing aspects of this study, led by our group of psychologists in New South Wales, Australia, who are really experts in illness anxiety disorders, looked at somatic symptoms, the thoughts, feelings, and behaviors related to these symptoms, predisposing factors such as age, but also any sort of adverse experiences or personality negative affects that this patient may have, and maintaining factors, somatosensory amplification, a condition called catastrophizing, and also any diagnosis clinically of anxiety or depression. The different scales that we utilize have interesting names, but I will just run through them briefly. There is the Somatic Symptom Scale 8 Original that looks at the typical somatic symptom complaints that the general population would show up with. And so we asked the patients in all cohorts to rate their experience with 8 common systemic symptoms in the general population. And you can see at this chart how this falls with the SSBI and the non-SSBI and mastopexy groups and the statistical difference between them. We then set out and included 18 additional symptoms, which are commonly attributed to SSBI. And these are such things as the brain fog, hair loss, fatigue, some of the systemic symptoms that you see all over the websites that are in the BII groups. And again, we looked at maintaining factors, a tendency to perceive normal somatic and visceral sensations that you and I would consider normal as being relatively intense, disturbing, or noxious. And again, you can see the p-values between the SSBI and the 2 control groups. Maintaining factors, these are a tendency to exaggerate the threat of a potential illness or symptoms. And the higher scores indicate illness anxiety disorders. And again, we were able to find in the catastrophizing scores exaggerated negative orientation towards their physical symptoms. And maintaining factors, over the last 2 weeks, how often have you been bothered by the following problems? And again, with generalized anxiety disorder and the patient health questionnaire for depression showed a clear difference between the SSBI group and the 2 control groups. Pat McGuire summarized this for us into a really nice little scale. And I think that the point of this was to show that all scales were highly statistically significant between the SSBI cohort and both control groups, with the only exception being when we tried to dive into a patient's history of a PTSD or traumatic events. That did not seem relevant in our study to differentiate the patients between the SSBI groups and the 2 control groups. So the beliefs and emotion studies helps to determine whether SSBI should be classified as a somatic symptom disorder. Do these patients have one or more somatic symptoms that are distressing or result in a significant disruption of their daily life? Do they have excessive thoughts or behaviors related to the symptoms, including a disproportionate and persistent thoughts about the seriousness? Do they have excessive time and energy spent and devoted to these symptoms or health concerns for more than 6 months? So what did our paper show in this last bit of research that we performed this year? It showed that SSBI patients tend to meet the criteria for somatic symptom disorders. They have significantly higher levels of symptoms. They have persistent thoughts and high anxiety, time and energy devoted to these symptoms. They have more often demonstrate a negative affect. They have maintaining factors, symptom catastrophizing, and somatosensory amplification. And if you look at the data out there on the proportion of patients meeting SSD criteria in the general population, it should range about 5 to 7%, with women having a slightly higher incidence than male patients. But in our study, we found that the SSBI cohort had 18 times higher than the non-SSBI cohort in meeting the criteria for somatic symptom disorder. So what does all of this research over the last 5 years tell us? How should we approach the SSBI or BII patient in 2025? Well, for symptoms to be medically unexplained, physical illness must first be ruled out. We are physicians. In the study and along the course of evaluating these patients, we have seen many patients coming in with actual medical illnesses. Mindy Hawes had a patient with colon cancer. I had a patient with neurologic symptoms who had a mercury poisoning from her pescatarian diet. We've had patients with different types of tumors and medical illnesses that were not recognized by their naturopath or the website that was leading them in this direction. Number two, physicians really need to be less afraid of the diagnosis of a somatic symptom disorder. We do no benefit to our patients by ignoring their high levels of anxiety or depression and by just performing surgery on these patients, which may prove to be unnecessary should they undergo proper psychiatric evaluation. Consider the effect of social media on what we call the psychologically vulnerable patient. Patients who have a tendency to sit online, to join these groups, and to get support online from uneducated and non-physicians who are leading patients towards unscrupulous practices. BII is a diagnosis of exclusion, but that does not detract from the suffering and disability caused by the stress and anxiety that these patients have. So take all of the information, sit with your patients, and the best advice is to give them a frank discussion of what we have learned about BII over the last several years of research and be open with our patients. Thank you.
All right. Thank you so much, Dr. Glicksman. Wonderful overview. I have to say on behalf of our editor-in-chief, Jeff Kinkle, and previously Dr. Fuad Nahai, that we're so thrilled and honored that you and Pat and Mindy and Dr. Caden, everyone else on your team, the research team has chosen ASJ as the go-to publication. It's great to have everything sort of aggregated in one place for us as publishers of the journal, and then also for practicing physicians. So thank you so much for that. We appreciate it. Let's see here. So I welcome everyone to put their questions into the chat box. We'll jump in with the first ones that we're seeing here. So Dr. Siham Azaf, he has two questions. He shared an article from BMJ Open talking about the difference between explantation before and after 10 years. What are your thoughts on this?
Okay. Yes. Well, we like I said, we saw that paper, and we've seen other papers that are similar, and in their advice that things get worse after 10 years. And so we went back and looked at our literature to see if the time in place made any statistical difference on the symptoms reported at baseline or symptom improvement, and we found no difference. And I have Pat, you are live as well, right? Are you muted?
Yeah, let's
Yes,
unmute her.
yeah, I'm on.
Can you respond to that as well?
Yeah, I mean, it would make sense. You would think, see, maybe the longer they were in, the more chance you would have of issues with them. So that's why we went back and looked at this data in our patients, and we did not find whether the implants were in for 30 years or 5 years. We did not see a difference in the symptoms or the symptom improvement after explantation.
Okay. Next question that he had is about, let's see, how do you know the symptoms are not the result of the SBI, secondary to BII, or the emerging risks of SBI, or unrelated to SBI? And have you measured these scales before implantation longitudinally?
That's a really good question is, chicken versus the egg. These patients have the symptoms before, they develop it afterwards. Steve Bresnick had a paper in ASJ, I think last year, where they went back and looked at the history of patients. They had the patients' medical histories from before they had implants, and they found that a lot of these patients did have psychiatric diagnosis or treatment prior to implants. But probably more importantly, there's a study that's sponsored by the Aesthetic Foundation called the STAR study, looking directly at that. They're following patients prior to placement of implants and then following them for years afterwards to check for the development of symptoms. Because, how can we say that these patients didn't have the symptoms till after they had their implants or didn't have them before? So this is going to be a very important study prospectively looking at symptom development after implants are placed.
Right.
Thank you so much. Next question from Larry Weinstein. So he's commenting that he had a patient with silicone implants and multiple joint pains. Her Lyme titers were equivocal. He put her on doxycycline, 100 milligrams per day for a month, and her joint problems resolved. Lyme disease is endemic in the Northeast. Is that something that you've looked at, had any patients with, or comments on that?
I mean, well, there's a lot of reasons for joint pains in, sort of perimenopausal, middle-aged, or even younger patients. And certainly that's why I said they need to come in with a real medical diagnosis and a real workup. So unfortunately, a lot of patients will just be misled. They're seeing naturopaths, they're getting concierge, medicine where they're being told online that clearly this is a problem, and they're not getting accurate workups. And so therefore, we felt that it was really important to listen to these patients, but actually make sure that these labs are real. The things that they're testing for, are they actually looking at common illnesses and ailments? Have they seen an orthopedic surgeon? Have they seen a rheumatologist? And the typical rheumatologist, maybe in the 80s, would say, well, you have breast implants. A typical rheumatologist nowadays will say to the patient, from their literature, they don't see any connection. But I think most importantly is that we backtrack a little bit. They may come in with stacks of papers, but none of them are really looked at their real issues. Like my patient who had a, pescatarian diet, meaning she totally had mercury poisoning, and nobody even thought to ask her that. So again, proper workup. And as Andrew did, Dr. Weinstein did, we are doctors. We have to treat these patients. It shouldn't be our responsibility, but certainly making money off of explantation surgery and getting them in the door and feeding all of this does not necessarily help the medical condition of that or psychological condition of that patient.
Absolutely. And I really appreciate you taking the time to sort of lay the groundwork here. So in the last 5 years, you mentioned that one of the first articles you published was in 2019 in ASJ. So what has changed in the last 5 years besides the literature that you've been, researching and studying? So how did the pandemic affect this? What's been happening in the last 5 years specifically? And where are we now? That's kind of the title of this talk. Where are we now and what's on the horizon? So what was the landscape looking like pre-pandemic and where are we now?
I mean, we can both answer this, but it is very clear. When we began this and we were at either the ASPS, meeting or the aesthetic meeting, there were panel after panel on BII. They were coming up, they wanted patient advocate groups there present. It was growing. It was rapidly growing. And obviously that was pre-COVID, which sort of took a lot of these social media platforms and knocked them down for a few years, but it was growing. And if you look back at the last several years of our national meetings, there's barely not even one BII panel anymore.
It's so interesting. I've noticed the same thing exactly. So,
And one of the things I think is, I had my daughter is now a resident in plastic surgery, but she was sitting in a clinic and a woman came in thinking she had systemic symptoms, and she was with her partner, and the physician pulled out one of the papers from ASJ and actually spoke to the patient and confronted the patient with real science and calmed the whole situation down and began to talk with some real information. And I think my daughter was like a co-author on the paper, and she was
I remember.
sitting there just saying, she didn't say a word, but she said she could see that physicians around the country who were looking for some way to communicate to their patients had some ammunition to speak to them. So, and Pat, your thoughts on that too, where you see the trends going, because you're in a lot more in these groups and watching what's going on with them.
Yeah, I think what 2019 with the device hearings and with all the real concerns and very legitimate concerns about breast implant associated malignancies really made people talk about this, which was a good thing. I think a lot of what has happened in all of this is our fault as physicians and manufacturers' fault by not talking about these things, by not looking into all of the details of what's going on with these women who really felt like they were being ignored. So we started talking to these patients and seeing what their concerns were. And after the FDA hearings, I think the FDA made a very good move with the patient checklist. Because the thing we heard a lot from these patients was nobody told me they were risk. Nobody told me that the implants were not lifetime. And I think now we have these checklists where we are forced, even though, I mean, those of us who went through the 92 moratorium, who've been talking to patients about implant risks for 30 years, it's now making everyone have this discussion with their patients and having open discussions. And what I tell my patients now is, we don't know what could happen in the future with implants. If you're going to be worried about it, maybe it's better that you not have an implant. Now we have data where we can actually have reasoned discussions and scientific discussions with it. I mean, yesterday I sent a video that I saw where a BII advocate was telling a story about how breast cancer patients are under a greater risk from their implants than they were from their breast cancer. And those kind of things are still out there, but now we have answers we can talk to patients about. One of the things I say with the capsulectomy is, do capsules go away? That's another thing I hear from my patients a lot. And there was just a paper published in ASJ, an animal study, looking at what happened to capsules after implant removal. And they did not see, and they saw the capsules kind of lessened in the inflammatory markers they saw in the capsules. I don't believe capsules completely go away. I think it's normal scar tissue in some patients. But and how many of us have gone back on a breast reconstruction or a mastectomy patient who never had an implant, and you see something that looks like a capsule? So we can now have those discussions because of published data looking at what happens to capsules. And we have to have a conversation. If you have a calcified capsule, it can cause you a seroma later on. It could cause a potential interference with your mammograms. But now we can have discussions with scientific data. And I think ASJ has really been, now this is a bit self-serving as a section editor, but I think we really have reviewed all these papers and published things so that we can have good conversations with our patients.
Thank you so much, Dr. McGuire. I do want to get back to the advocates, but we're kind of blowing up in the chat box. So I want to make sure we get to all of the questions from our attendees. So Dr. Edward Powers is saying it would be difficult, but have there been any studies performed using functional MRIs of the brain and somatic symptoms?
There was a paper published in ASJ looking at functional MRIs because fibromyalgia patients do have abnormal MRIs. I forget what part of the brain they see it in. So there was a study done in the Netherlands looking at functional MRIs, and they did not find a difference in the functional MRI between BII patients and controls.
Okay, thank you. Dr. Jean Loftus is saying about 20 to 30% of her patients who present with SSBI have saline implants, not silicone. This is disproportionately higher than she expected, as saline implants account for 5 to 10% of all implants in her region, which I'm not sure what her region is. Maybe she can put that in the chat box. Has anyone else seen this, Dr. McGuire or Dr. Glicksman?
Well, we did see, it depended on our site. One of our sites is located in Atlanta. She had quite a few. It depends on how many years. If they were patients that their implants were in 14, 15 years with the saline implants, it was during the moratorium. So even though it may not be proportionally high in the United States now, if those implants were in that time period when that was really predominantly what surgeons were doing, obviously now it's less than 2 to 3% of the sales is saline implants in the United States. So it really depends on the time at which that was placed, the location that it was placed. And you see, it's really interesting, is it a silicone problem or is it not a silicone problem? It doesn't really make a difference which manufacturer. It's what chat group that patient's in, it's what symptoms they have, it's how they dwell on those symptoms, what they believe. And, it's really simply a matter of the outside influence on these patients, because whatever story they have, they can find a website or a chat group that'll support them. There's something
Absolutely.
toxic. There could be mold in the water. There could be something. Well, we tested for all of that. We looked for molds. We found 0 molds in the capsules, and we had 60, like we said, over 65% saline implants in our study. There was no mold identified at all in our study anywhere. And then, it's just really depends on the patient, and I think where they're influenced and what social media that they've been reading.
It's a great point. I feel like this BII community is so tight knit, and they're, like you said, the Facebook groups, the different influences. So I feel like this is such an anomaly compared to other procedures and diagnoses. So Dr. Loftus did just mention here that all of her patients were post-moratorium, not during moratorium.
Yeah, we had
Okay.
64% saline in our study, and it's not related to the type of implant, the fill, the texture. We wondered would they be higher in textured implants versus smooth. It wasn't higher rupture versus intact implants. We actually had more ruptured and more textured implants in our non-BII control than we did in the BII cohort. If you look at variations in the world, what's the most common implant for BII in different parts of the world? It's whatever the most common implant is that's being used in that part of the world.
Regionally,
Yeah.
right, right. Good point, Dr. McGuire. Now, let's see, we're moving on to a question from Dr. Lauren Daly. She's saying, would you be able to comment more on the finding of oxylipin, hope I'm pronouncing that right, being elevated in some breast capsules? Is the finding that it's higher in some BII patients believed to be not significant?
And that's a
Is the
tough
finding
question because it's a very interesting finding. It was a good study. It was published in ASJ. They've had a couple of papers published in different places. And the suggestion by that, the 10-home oxylipin is what they found to be higher. 50% of their BII cohorts had elevated levels of this 10-home. And so the question is this caused by staph infection? Well, one of the things that we looked at were staph enterotoxins and the presence of antibodies to those toxins. We did find staph enterotoxin A was statistically higher. Nobody knows what appropriate levels are of any of these things in the bloodstream, but we did find statistically higher levels of antibodies to enterotoxin A in our BII cohort. But the interesting thing is, so that's suggested of a previous staph infection. The interesting thing is we went back and looked at our PCR testing of the capsules on those patients, and none of those patients had staph in their capsules. So if the cause of their symptoms was a previous staph infection, it seems to be unrelated to the implant or to the implant capsule. I think there's the problem with BII is it's not an individual thing. You wouldn't have 100 different symptoms if it was all caused by the same thing. So maybe there are some patients who've had subclinical infections as a potential cause of their symptoms, but it's not in all of the patients. So that's why I think this is so difficult, is I don't think we're dealing with a one thing. It's multifactorial, and it's just different in every patient.
Absolutely. And now Dr. Anthony Yoon is with us. Hi, Dr. Yoon. Good to see you. And this is a question for both of you. I'd love to hear both of your different perspectives or maybe similar perspectives. So what do you answer when your patients ask what percentage of a chance is there of developing BII symptoms after a breast dog? And he's saying he'd love to give them an actual estimate, but understands it's a bit more complicated than a simple percentage. So what do you say if they raise that question to you during the consult?
Before they'll even ask me that question, I ask them some questions, and I will ask my patients about any histories of eating disorders, any histories of anxiety. Did they take any medications for anxiety while they were teenagers? Do they have any other history of depression? Do they have any other issues? Do they spend a tremendous amount of time on social media? Are they influenced by these things? Do they have what we call modern health concerns? Do they have a lot of concerns about groups of patients who don't want to get mammograms nowadays? They read a paper somewhere. So I will throw it back and ask those patients, because to me, those are the patients that are going to be strongly influenced by these outside influences, such as the chat groups, the groups, and any symptom that they get. We all get generalized symptoms as we age, and that is the leading reason that people seek out medical care, are just generalized vague symptoms that they can't always find a cause for. So I tend to turn it around. Can I tell a patient you have an X% of getting BII? Absolutely not, because we see the trends changing. How prevalent was BII before COVID, and then you could see it online, all the searches for it, then you see the searches decline when something else came along. If Lyme's becomes big or COVID comes back, where are they searching? So I can't specifically say that there's a risk, other than what's your history and how likely are you to have more anxiety than it's worth. And that's kind of the way I turn it. And Pat, what do you have to say to Dr. Yu?
But I'll tell patients, I can't tell them their percentage risk. I think the percentage of implant patients that may report symptoms or have concerns about this, I usually tell patients 2 to 3%. If you look at most studies, 97, 98% of patients are happy with their implants. So I usually tell patients, I think, there's a percentage of patients who aren't happy with it. And tell them the chance could be, it could be anywhere from 0 to 10%. I heard a so-called explant expert say that there were 20 million women in the world with BII, and I have not seen where, I didn't understand where he came up with that number.
Interesting. Okay, let's see here. We've got a question from Dr. Azahav asking, how do you treat leaked silicone-induced inflammation?
Leaked silicone inflammation. Well, both of us have ultrasounds in our practices. I ultrasound my patients and assess them if they're young and they haven't had any outside imaging. We're following my patients closely. If somebody has a leaked silicone implant, the idea is to get that out. Nothing good happens from leaving a ruptured silicone implant behind. And obviously, if it's late and there's extracapsular gel, I don't think that there's any silicone illness. There's not really any silicone levels that can be detected. So I think it's a matter of getting good mammography, cleaning out as much silicone as you can, obviously, and making a decision whether or not that patient ever wants another implant. And that's I just treat it as the local complication and making sure that patient has good breast health. Inflammation, like silicone presenting in a lymph node, it's going to be there forever. There's not much you can do, but I think you can preempt that by having good follow-up, following your patients, using ultrasound, and getting those implants out if they're ruptured as soon as you can.
Okay, thank you. Now, this is a little bit more of a kind of a thought, like a think question. So thinking about artificial intelligence, there's so much going on with that in plastic surgery and even in publishing on my end on the ASJ side. So can you think of any ways, or have you heard of any ways in which AI can add anything to the causes of BII, or is there anything coming out of AI that could be an influence in this space? And if not, that's fine too.
Two of the least technically
yeah, two of the least
computer
technically
AI
AI forward-thinking surgeons that are out there. Obviously, I think it doesn't help when you have things like these meta-analysis papers that come out. So if it's something that would be gathering, just looking at all of the papers published and generating some generalized ideas. The problem is when I look at meta-analysis, systematic analyses of things, and that's kind of the way I'm thinking that AI would work, to kind of review all the literature out there, all the findings, all the symptoms. The problem is, crappy data in is crappy data out. And so there's so much bad literature out there over the years with these case reports, and nothing that would really validated that there was anything other than an association between an implant and self-reported symptoms. I think that's a problem. Perhaps as we get to the point of having maybe some types of questionnaires that we could give to patients before surgery to assess them psychologically, things like that. Perhaps maybe that will help us be better judges of who shouldn't have a breast implant. But other than that, I don't know, Pat, can I turn it to you again? And
I think it's all, this is where things like the STAR study, prospectively following patients after implant placement, is going to give us a lot of information. And it's a shame that none of this has been done. And those of us who lived through the 92 moratorium, why wasn't this data collected in the last 30 years? Why did we have to do this study now? And I think, a lot of this could have been answered a long time ago, but we're in the process of doing it now. As the president of the Aesthetic Foundation, if you all are not members of the foundation that can support this type of research, I'll take the minute to plug that, or if you want to make a donation to the foundation. These are the kind of things that we have to do now. And there was recently a study with 7 patients that had new implants. It showed that there was silicone in the capsules of these patients. You think, well, that paper could show up in an AI search as saying, well, look, you can have an implant in for 3 weeks and they have gel in there. Well, that paper didn't say whether patients had previous implants, didn't say whether they had previous ruptured implants, intact implants, the type of implants they had, how the procedures were done. So as Caroline said, bad information in, bad information out. So you kind of worry about what's AI thinking and what's it doing.
Absolutely. And I'm going to post a link here shamelessly to donate to the Aesthetic Foundation. If anyone is so inclined, we'd appreciate that consideration. So I said we'd get back to advocates. So Pat, how have the advocate groups shaped the regulatory decisions that have been made, and how have patient reported outcomes kind of been a part of all of that? Caroline mentioned the advocate groups wanted to have an exhibit or a booth or a session. I was there at the ASPS meeting when that happened, and then when they approached our aesthetic society to do the same the following year. So how has that group or movement shaped what's happening in BII and how we handle it?
They've been very important in bringing this to the forefront, to make people listen to the concerns these patients have, to remind us that we have to look at things from the perspective of our patients, and that what these women are reporting is real. I mean, they're not hypochondriacs. They're not making these symptoms up. And all for, the surgeons who've blown these women off for years, they made themselves heard. The reason we see these big groups of patients banding together on social media is because they weren't getting the support they needed from their doctors. They were being blown off. And, I think they were very important in getting things through. But that you also have to be careful, because there's as much misinformation as real information on these. I'm involved in a collaborative community, FDA collaborative group, that has patients, it has industry, it has surgeons in it. And we're trying to work together. And it's been very valuable for me. We have ALCL survivor patients, we have BII patients in this group, to hear the other perspective. When you're in your little bubble, you hear what you want to hear. So I think it's been a very important, to listen to these patient groups. But now we also have to police some of these groups, because what's being said in the groups is not always 100% scientific. And they're presenting things that are these small case series, these small, 2 or 3 cases, no long-term follow-up, no control groups. There's one paper that's gotten a lot of press that the follow-up was 50% of the patients were followed less than 30 days. So, what kind of information can you get from that? So I think the groups have been very important. I think they've done a lot of good, but you also have to be careful, because there's also harm been done because of some misinformation. But same thing can be said from any group of people at any point.
Sure, exactly. All right, we have about 6 minutes left and the questions keep coming, so fantastic, love that. Dr. Larry Leverett is saying if an asymptomatic patient has residual silicone seen on imaging after explantation and capsulectomy years earlier, is there an indication to remove it surgically?
From my base of knowledge and experience for 30-something years, absolutely not. It depends on whether they actually formed a siliconoma. I had one patient that had a pretty large size siliconoma on her chest wall. And I did send her up to Sloan Kettering and have that resected because it was palpable and it bothered her. And it really seemed to be interfering. That was a good large size piece of silicone that was left behind. Very different than that small little sort of a whitish snowstormy scatter that you can see from a very neglected implant where there was extracapsular gel. So to trace after that and go after that, we have no basis to say that silicone is making that patient sick in any way. And what's the morbidity of going after it? Will you produce even more scar tissue that's going to show up on future imaging and have her being pulled back in several times? Once it's pretty steady and stable, the radiologists are going to see the same image year after year. I don't think from a breast imaging perspective that you have to chase after that. Certainly, if it's something that's physically palpable or annoying to the patient or close to the skin surface, that's different. Then that's when you would go after it. But most of these are pretty benign. And once they've had a few years of imaging, the radiologists say no changes from previous images. So I don't think you have to chase after silicone.
Okay, thank you. This is an interesting question from Ed Powers. He's asking, are there any ethnic differences in the prevalence of BII? Has any of your research addressed that?
Ed Powers, you're the only person that has your camera on. I just thought I'd let you know that, but I know Ed for many, many years. So it's good to see you. I don't think that we found any ethnic differences whatsoever in our group. It's just certainly the patients who are enrolled in the study in the specific cities that we picked. That's why in our last study, we did 8 sites, and we actually, one of the best things we did this time is we added in geographic locations to get more diversity in the demographics, including the UK, to sort of get a little bit of a sort of a European migrant, whatever population. So we've added in more geographic locations to make sure we didn't have any bias by having just East Coast physicians or Midwest physicians. So,
And there's not a difference ethnically. There have been studies that show a lower incidence of systemic symptoms in transgender patients and in cancer reconstruction patients.
Okay, thank you. Let's talk about the manufacturers, the implant makers. So Allergan, Mentor, Sientra, formerly Sientra, now Tiger, and Motiva most recently. How have they responded, adapted, evolved as a result of these concerns in terms of box labels and product design or anything like that? What are your thoughts and experiences?
Well, the manufacturers have, their DFUs, their directions for use, and they have to, add in the different labeling requirements as per every one of these advisory hearings that comes out, and then makes any sort of documents and guidance from the FDA. They must comply, and anybody selling implants in the US must comply with those. So all the manufacturers now comply with that. I think one of the things that the manufacturers finally realizing is that their donations matter, and that they should be donating to things like, they donated considerably to the Aesthetic Foundation, sort of a, unrestricted grants where they're actually funding us a little bit to do some research. We don't want it to, it always appears biased to the patient groups if the money actually was supported by industry. So that's why we did things through the foundation itself. And industry just hasn't supported any of these types of research things because it becomes perceived as biased, that their patients aren't going to get accurate information. But they did contribute unrestricted grants to the Aesthetic Foundation, the Aesthetic Society, to do this research. So we have to say we appreciate that.
Absolutely. And in our final moments here, I'd love to have each of you just kind of any last minute thoughts, anything to wrap us up here or give us a little taste of what we're looking forward to in the future in terms of your research that's coming up.
we have a pilot study we hope to start soon for our next. I mean, we keep trying to turn over rocks. We were hoping we would find the smoking gun. We were hoping it would be a biofilm or something reversible, easily reversible or treated, or some diagnostic test that would be different between the BII and the control groups. And we haven't been able to find it, but we're not going to stop looking. We respect the concern the patients have enough. We respect plastic surgeons' concern for their patients enough that we keep wanting to find it. So if anybody has any ideas, let us know. And we're good at putting together studies and getting them done. But we do have a pilot that we're working with Indiana University for another potential avenue of this stuff. But I think we have to keep looking. I think we have to keep working with the patients and all working together, and not ignore these patients, which I think got us into trouble in the first place.
It's a great message. Caroline?
I think my only last words are that, unfortunately, I think a lot of what goes on by plastic surgeons is that they find a niche and they find a way to make money. And I can't get off without being the ethical, moral compass of all of this. And I do find it disheartening when, with even all of this literature that's out there, that there are still sites that are just self-promoting themselves and taking advantage of women. So I think certainly all the people that are on this call today aren't the ones we have to address, but it's really just this, trying to make sure that we're doing the right thing for our patients. If they do have symptoms, they have the right to remove their implants, but we certainly want to get to the bottom of it and not blame the implants for every ailment that these women have, or take advantage of them financially. So my goal really was to keep surgeons ethical and getting the research and the literature in their hands so that we can manage these patients safely and do the best thing for these women. If they don't want an implant anymore, take your implant out. It's as simple as that, but you don't need excessive surgery that may make you sick or disfigured. And I think we accomplished that over the last 6 years or so. And I just hope that we can keep looking and making answers for the patients, because that's what it's really all about.
Excellent. Thank you so much, Dr. Glicksman, and President of the Aesthetic Foundation, Pat McGuire. Thank you for being here and being her co-conspirator and advocate and co-researcher. You guys are wonderful. This has been great. We are recording it, so we'll have this available on the Aesthetic Academy in the coming weeks. So if you have any need to kind of re-review it, feel free to do that. We do a journal club coming up August 12th. So more information is going to be sent out soon about that. So with that, I'll say thank you again, and to everyone, have a good rest of your day.
And thank you to the
Bye-bye.
journal. Thank you.
Thank you.
Bye-bye.